Welcome everyone to today's webinar, Crisis Recovery, How Clinical and Financial Data Integration Can Help Hospitals Restore Revenue Health. I'm Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link used to log into today's webinar to access the recording. At this time, I am pleased to introduce our presenters for today's webinar. Terry Henderson is a director at Allscripts Solutions Management. He is joined by his colleagues Angie Ray, Carolyn Fallon, and John Ranzo, senior managers with Allscripts Solutions Management. At this time, I'm pleased to turn the floor over to Terry to begin today's presentation.
Thank you. Okay, thank you everybody, and good afternoon, good morning, depends on what part of the country you're calling in from. And I am pleased to talk to you today about what's going on with the crisis with some of our clients and some of the responses we've had and how things have gone and so on. We're going to do the introductions, which was just done, and then we have the global crisis as one of the topics we're going to discuss and how those impacts have transitioned across the country, across our clients, and so on. Benefits of the integrated platform that Allscripts has and how we could quickly react to that and help our clients and mediate their needs and so on as things that came up that were unexpected, of course. Things that had to do with their financial impacts and so on that we could help mitigate any problems. Organizational impact for COVID-19, what did that mean as far as how did it affect the staffing? How did it affect the overall performance of the organizations and stuff like that? And then we're going to have attendee questions and answers. So as we move over to the global healthcare crisis, as we can see, the things that we're familiar with right now, and this means that, all of us have experienced this, is the personal protection equipment, the PPE, meaning the face masks, the things we had to do as far as having certain precautions put in place, the protections and stuff like that. Social distancing, of course, is one of those, and that's how we interact and all the things that came because of social distancing and the things that are still in place. As I go into our local stores here, and I'm from Pittsburgh, Pennsylvania, I see that a lot of these are still intact, still in place, and some people are mainly abiding by them, where others are starting to free up a little bit. But the thing is, most important is that we're never going to forget the crisis because of the things that has changed on us and how it has brought those challenges to us to deal with on an ongoing basis. Big impact, of course, was our working location. A lot of people, including us, had to work from home, and that was a big challenge for us to make sure that we could do that effectively and react with our clients as well as with our peers to continue with our operations. So the personal protection equipment is unprecedented times, right? So of course, everybody has their own disaster recovery drills they run on a regular basis and so on, right? And they get into this situation where once they need those resources, because they never know when it's going to happen, they go and they have to now enact on those resources, and they find out that maybe they're not as many as they actually need. Maybe they're not the shape they needed. So we've learned a whole lot with our healthcare workers as well as with all industries on what we need to do during these unprecedented times. So as we go through these times, hopefully there's none in the future, but if there are, we're going to be much more prepared. Extraordinary measures, providers have to basically limit the number of patients and stuff that could come to the hospital, as well as look at how best to treat them to prevent the spread of illness and stuff like that. And then the precautions, this ranges multiple ways with our hospitals that we service, and that some had to go to having patients come up into the parking lot and do tests and stuff like that. So there's all types of processes we've all learned from this, and these are good things going forward because it's only preps us for the next case if we ever have one. Okay, a global crisis has no boundaries. As we all know, most of us who are on the call were involved in the healthcare side of it, right? But when you think about it, it's not just healthcare, it's everything across the globe, right? So we have every industry out there that's been impacted, and we have to look at that and say, okay, so if everybody's impacted around that, what are those common things that we're going to see on an ongoing basis, and how do we prepare from that, okay? So when you look at it, everybody has a certain common degree of this, right? And then the facility, the volumes are significantly dropped as far as patient volumes, okay? Now the hospitals have to ramp up their testing, and the procedures are limited, and that is down to what's very urgent or critically needed, right? Healthcare reimbursement gets impacted from all of that. So we have to become very creative and think of ways that how do we not only survive during that time period, but how do we rebound also during that time period, right? So we're going to, as we further develop our applications, as well as everybody in the industry has to work with these operations in their own facilities and so on, this will be on their mind about how these impacts have impacted them going forward, and what do they got to do the next time around, right? So one of the things also has to do with our KPIs, our performance improvement indicators, right? We have to look at those and say, a lot of those may not be effective during this time period. So what are the ones that are effective? And we're going to get talking about those a little bit later in the presentation. But what's interesting about that is it's some of the things that you won't expect that people have to go to in order to make those financial performance indicators be realized in a better state, right? And we're going to cover that in just a little bit, but I just wanted to let you know that that's one of the things I want to make sure we get to. So everything works together. As you can see, the cogs go in the wheels here. So these are the processes that have been set in place prior to pre-crisis, right? So as patients come in to a hospital, right, they have the common payment eligibility process that they go through, and then they, of course, those have to go up to the medical coding and then the claims clearinghouse and the medical insurance payers. Now I'm going to cover that again now. Now we're going to do it with the coronavirus impact, right? So now we have those services that are beefed up in certain areas for coronavirus and other services that have dropped off, right? So we depend on all those cogs all the way through there being seamless. We depend on that being in place, and when we have a crisis, we don't know how this is going to all react, but the good thing about it is that through our Allscripts partners and so on, we've had a very good seamless integration with them and being able to pass our information all the way through, from payment eligibility through the medical coding, claims clearinghouse, and medical insurance payers. And keep in mind, every one of them were impacted just as anybody else in the globe was, right? So each one of these businesses have their own impacts to deal with, but everybody kept the ball moving, okay, to make sure that we were able to get through this, and we will be able to get through this in the future. Next, I'm going to ask Angie Ray to speak to this integrated platform.
Thank you, Terry. This is Angie Ray, and as Terry mentioned on the last slide, everything works together, and it does with our Allscripts solutions. Our Allscripts Sunrise platform is a single platform, enterprise-wide EHR system supporting workflows seamlessly across all inpatient and outpatient care settings under normal circumstances and effortlessly during a crisis. So what does Allscripts offer? Single patient record, and accessible whether the role in your organization is within revenue cycle, surrounding clinical workflows, or across the enterprise. Orders to charge integration, this is real time, not a batch process. Shared dictionaries and configuration tools so you can quickly enable telehealth services, all under one platform. Here I want to orient you to our Sunrise platform. In this slide, it is shown in the midsection in a pretty pale blue. Our Sunrise platform, which houses our Sunrise applications, allow us to deliver clinically integrated revenue cycle workflows. In an evolving value-based care environment, the key for success is sharing information. Now, very few solutions actually seamlessly share information, and I don't mean the transfer back to interfaces, but that actually share the same database. Now, placing our focus on Sunrise Revenue Cycle and Sunrise Clinical sitting nicely on top of our Sunrise platform, and where an actual performed by booking a patient for an appointment can initiate workflows. An eligibility inquiry triggered before a scheduled appointment allows our patient engagement product, Follow My Health to our left, to include the copay amount from an eligibility response as it sends an appointment reminder. That appointment reminder opens opportunities for other actions, such as obtaining a confirmation on the appointment, of course, validation of demographic information, as well as offer the opportunity to pay that copay amount earlier obtained through that eligibility response, and where the payment collected is reflected real time on the patient's account. When the patient arrives and electronically checks in for services, we can alert clinicians on the patient's arrival, again, without a transfer back to interfaces, but based on actions updating the single database where every resource can see the most current status on the patient's record. I want to now orient you to the area under our Sunrise platform. You can see first our Allscripts Clinical Performance Management, where the Sunrise clinical and financial information flows naturally into our business intelligence solution. It offers pre-built or customized reports and dashboards and empowers healthcare organizations to monitor clinical and financial performance, which allows you to improve patient outcomes and reduce cost. Sunrise aggregation of clinical and financial information in our clinical performance management flow into EPSI for knowledge-based decision support on a single integrated platform for contract management, contract modeling, and cost management at the episode level, in addition to strategic planning, product line budgeting, cost accounting, and operational and capital budgeting modules that are part of a decision support system. I have a couple of use cases that are brought to you by our Sunrise Revenue Cycle and highlighted during this pandemic. The first one uses functionality that was originally designed for what can be described as occupational health billing or invoice billing. So say an agency sends their employees for employment physicals to your facility and need to be invoiced for services at contracted rates, but not through a formal claim form, such as a UB04 or 1500 form. Our Sunrise Financial Manager product supplies out-of-the-box invoice forms for which you can replace with your own custom forms. We had a facility that embedded this widely used functionality for charges generated based on COVID-19 testing for their own employees. They set invoice billing to be generated monthly and expect the reimbursement to automatically adjust off the balance. Data from the insurance plan assigned, as well as the adjustment codes generated, provided analytics to Sunrise Financial Manager's own standard reports, as well as through our clinical performance management and EPSI. The second use case leverages strategic partnership with Enthrive. The HRSA COVID-19 Claims Reimbursement Program provides reimbursement to healthcare providers that provide testing and treatment for uninsured individuals affected by the pandemic. There are two key factors here. One, you must enroll as a provider, and two, upload the eligible patient roster to the portal to obtain a temporary ID. With our Sunrise solutions, you can create a visit, assign an HRSA insurance plan with that temporary ID you obtained earlier, and then with Sunrise Financial Manager pre-claim edits powered by Enthrive, you can resolve coding compliance conflicts, preventing rejections on either professional and or institutional claims. For example, the diagnosis must be a COVID-related diagnosis and listed on the first position. Specific HCPCS codes must have corresponding diagnosis codes. Valid date of service, where date of service must not be prior to February 4th, start of our for the HRSA program, prior to February 4th of 2020, among others. You can also timely bill claims, as timely filing is limited to 30 days for the service date and 1 year to file per Medicare standards. Also, hourly, you can batch claims for HRSA insurance plans and submit for reimbursement. And since uninsured payments that qualify for the HRSA program cannot be balance bill, you can utilize functionality available with our Sunrise Financial Manager to automatically adjust off self-pay balances. And now I'm going to turn it over to John Ranzo.
Thank you very much, Angie. So at this point in the presentation, we're going to switch gears and talk about organizational impacts from COVID-19. Right, so we intimately know that COVID-19 has affected every aspect of healthcare, with those major drivers being the insidiousness of the disease, right? That includes the dramatic effects on the health of some of those people who have contracted the disease. For those who haven't contracted, the fear of the consequences of contracting that disease, right? The protection efforts that we've all put in place, specifically the healthcare providers, right? That what they needed to undertake to protect themselves. And the quarantining and lockdown orders that were imposed by some of the governments statewide and community-wide throughout the United States, right? And we know that a pandemic needs to be dealt differently and on a different level than standard operating procedures. And our healthcare providers needed to enact new procedures around most aspects of their operations. So in the next series of slides, Angie, Carolyn, Terry, and myself will explore some of these changes in more detail, from the leadership response to continue the healthcare mission, right? The effect on the patient volume and staffing, managing cash flow and receivables, and the recovery from the effects of the pandemic, right? And with this introduction, I return back over to Angie Ray.
Thank you. Thank you. A common occurrence currently seen within healthcare organizations like yourselves require their leadership to shift from an otherwise yearly review of emergency disaster plans into an active COVID-19 response task force to maintain viability. Topics of planning for sustainability, recovery, and restore will be covered in more detail by other members, as John Ranzo mentioned, members of my team on this presentation. Executive leadership had to right shift quickly from establishing infrastructure in support of their health systems, business, and clinical initiatives into enabling a remote workforce, scaling out telehealth options, monitor revenue and cash flow, identify non-essential resources and or services, and appropriate equipment necessary to handle patients with a highly infectious disease, followed by engaging the next level management to implement changes. And on the next slide, I'm going to turn it over to Carolyn.
Hello there, thank you. So regarding preserving patient volume, as you know, many of our hospitals and even places all over the world, but specifically for healthcare, there are less walk-ins, in some cases absolutely no walk-ins allowed. The volume with ER has gone way down. Elective surgeries were completely out, and in some cases, for one of our clients, this meant a full closure of the facility. So to preserve that patient volume, the obvious choice, which my colleagues have already discussed a little bit, is telehealth. One of our clients, in conjunction with using the clinical performance monitor, which is called CPM, part of our product, they use that for reporting to go over all the services and do a deep dive to see just what type of service they could provide in the telehealth setting. The obvious choices are their office visits that they could do, as well as post-operative visits. But what was interesting to us is they were also able to offer rehab services remotely. This included speech therapy, and in some cases, physical therapy and occupational therapy. So implementing the telehealth was a very clean way to preserve the patient volume and keep people safe. They also implemented testing sites for COVID, of course, using precautions to do this. And the third way to preserve the patient volume was to initiate some blood drives, again with some precautions. For those patients that proved negative and for the need for blood, they were able to offer some blood drives. Also, Follow My Health introduced universal queues, And this is a way for all patients, whether they were fearful of having contracted the COVID-19 virus, or if they needed some simple questions answered, they could go to the Follow My Health universal queue and know what their wait time was, and based on their provider and what their query was, they would be routed and could easily be served. I see this as a great way that had handled the no walk-ins allowed. And then finally, I want to touch on a different way of preserving the patient volume, in that showing the community that the hospital cares. Allscripts donated 25 iPads to Catholic Medical Center. And while these patients were already in-house, it did show the level of commitment that they needed to be able to communicate with their loved ones, since they were allowed no visitors. This shows the dedication of the hospital to their patients and to the community. I also have the next topic, which is staffing impacts. So as you know, across the world, there have been staffing impacts, not only with our organizations who are vendors, but also for our hospitals and clients and places all over. The most impacting one was the furloughs that have occurred. As you know, the current unemployment rate is very high. But with facilities closing and less services being offered, furloughs have occurred. The second one, which is widespread, is working from home. And there's a couple of things to consider with this. If you think of all the people who are used to working shoulder to shoulder, now have to go home, set up a designated space, bring all their equipment, whether it be multiple monitors in order for them to do their work, and realize that they're not as easily able to print as they would be were they in the office. So I find it quite ironic that this horrible disaster, this pandemic, brought about forcing users to be more paperless. We do have an EHR system where we're trying to encourage no printing, and now users are actually using that and not using the printer as much. And then there's impacts to vendors. So we're one of the vendors. Our clients said no more travel, and I'm sure even the hospitals themselves are not traveling as much. So these ripple effects that happen in our hospitals also affect other areas. They've had delays in upgrades, and so they need to find other things to do with their staff, which Terry, I believe, is going to speak to. And then talk about the people who've been impacted but still have to go to the office, even if they're not patient-facing. A couple of things had to be done in this area. One was they did rotating schedules. So while one person went to the office, the others would stay at home, and they would rotate who was in the office. Some had to do split shifts. So for those employees where I had to go to the office because it wasn't feasible to bring all my equipment home, what they did is split up the desks, make sure they're nice and separate and far apart, and then offer a first shift, have those cleaned in between, and then offer a second shift to come in, a second shift that would work later. All of this introduced some new roles and responsibilities, especially for those who are patient-facing. The staffing impacts included now having to disinfect and take precautions. The radiology departments and offices around are now taking temperatures, whereas before they did not. And sometimes there's even a curbside service where if I need a prescription and my pharmacy does not allow electronic, I would go to the office as a patient and then have one of the assistants run out the prescription for me. Those are just some of the staffing impacts that have occurred as a result of COVID-19. The next topic I'm going to hand over to Terry Henderson.
Thank you, Carolyn. So when you look at the topic of managing cash flow, it's one of the very important things that come into a facility, because now you have this depressed patient volume, right? So you don't have that same revenue that's coming in that you've had on a consistent basis. And you also have staff that have been moved around in different locations now, working from home, and all those things that are new. So there's a lot of new things that are happening. So a lot of the organizations have to now react to that and figure out what is it going to do, because they've had furloughs and they've got all these things impacting them. So they have to filter through all this, right? So one of our clients, they went through and, of course, with their task force, they put together a plan on how they were going to manage to keep their revenue good, afloat, those sort of things, so it's survivable, right? And so they went through this process where they looked at what areas did they have within their revenue cycle operation that they could pull from or manage from to increase or maintain cash flow, right? So one of our clients, they basically looked at what they had in their DNFB, okay, gave them an opportunity to focus resources on their DNFB and also to do some cross-training during that process too because of the limited staff and so on. And they successfully were able to look at their DNFB, bring those down to their baseline of what they were wanting to achieve earlier than that, and which was really good for them because this was able to maintain their cash flow and keep it going. But one of the other areas they looked at was their age receivables, okay? And with their age receivables, they were able to go out and tap those areas that were out there and work with their payers and look at that and say, you know, if we can get these group of individuals to work on this, staff to work on this part of the aging and another to work on the other ones and so on. But one of the things that they did is while they were doing that, they started strategizing on what their next approach would be, which was how do they plan that out? How do they optimize the receivables, right? So as you will see on the slide that I have here, you're looking at a matrix that was designed to make them make a decision on how to go after the certain types of cash revenue, right? So of course, the first one that they looked at was the high value and low complexity. So that people would refer to that as more of the low hanging fruit type situation, right? So they would go up there and they take a look at that high value, low complexity and figure out how much is up there, how much they're going to collect and be able to report that up to their CEO and their CFO, because those are two areas within the management structure that are very interested in knowing what they're going to have coming in the future, how long, no one knows how long the COVID-19 is going to last or what the depression of patient volume is going to be and all that sort of stuff. So this allowed them to do their projections from that and figure out what they needed to do. And then, of course, they moved over to their high value, high complexity, things that are a little harder to work, a little bit more involved in solving some of those outstanding cases that they had with the payer may have had a specific requirement that they wanted to fulfill, maybe documentation or something like that, right? So they moved over and they looked at that. But one of the things also to mention is before we move on from here is kind of those key performance indicators, okay, that they looked at. And we all know of AR days, and we know that what that means as far as the health of the organization, and you know the lower your number, the faster you're collecting your money and all that. But really, when it came into the crisis state, what people were more interested in was a key performance indicator of the average daily cash flow, okay? Because that's what really matters. Because you expect that you're going to bring down your AR because your volume's low and you're working those accounts that are older and your DNFB and all those sort of things. But that indicator became a very big indicator, followed by the discharge not final bill, the DNFB, right? So the DNFB basically said, okay, so how much do we have in there? What's coming down? What's our lag days? What's coming into that process too that we can also basically measure and net and figure out what we're going to be bringing into the future. And then on top of that, what other services, like Carolyn mentioned and Angie mentioned about the telehealth, okay? What are those services bringing to the picture? So now you have a whole new type of revenue cycle that you're trying to measure from versus the traditional side of things, right? And those are the things that are very interesting. And one of the notes that I'll mention is that even though the organizations who have performed their reserve calculations based on their age receivables now have to revisit that because a lot of that became collectible during this process, right? And this is a very good thing. And the good thing about this is that through Allscripts, we were enabled them to be able to go and change their work queues, set them up for the staffing that was there, move that around, change the priorities and the combinations within that allowed them to target these high areas of value, okay? And like I said before, the high value and low complexity. That was one area they could target there, then move to the next one, right? And of course, they left that a low value, high complexity to the end, right? So hopefully most organizations didn't have to get to that point, but they did a very good job restoring what they needed in order to keep their cash flow going good, okay? And I'm going to move this slide over to John Ranzo.
Thank you, Terry. And so with how the actual pandemic was managed within the healthcare organization, now we turn to the topic of recovery and restore and reopen, right? Many states have reopened for business completely, or some states have reopened only specific counties, and some areas are still remain in lockdown, right? We know that patients have delayed services, voluntary or not, and may be apprehensive about returning to the hospital or the physician's office in the near term, right? So these patients run the gambit of services needed, from something as serious as restarting your chemotherapy to something less serious as maybe needing a lab test that's related to a non-life-threatening diagnosis, right? So there needs to be a plan in place to re-engage these patients, right? Possibly from a marketing perspective, but there also needs to be plans in place around the physical plant, clinical administrative staffing, access management, access to the health organization, that type of access management, and also encounter management, right? That physician or clinician-patient interaction, right? So if you're in a state that has just announced reopening, you may not need a marketing campaign. But if you're in an area that is in a yellow, under a yellow color, in the red, green, yellow, meaning cautiously, optimistic, you may need to announce yourself to your patients that you are back opened and offering services, or maybe a limited number of services that are deemed non-essential, right? If there was COVID-19 patient activity at your facility, you need to let your patient population know that you have their health as the prime consideration in how you're handling the physical plant and also the encounter management with those patients, right? From a physical plant perspective, you may be extending some of the precautions and some of those new procedures taken while caring for COVID patients onto every other patient interaction, right? That may be something that's being extended hospital-wide now with opening up. You may be erecting plexiglass barriers between clinicians and patients, or registrars and patients, ongoing, or until at least hopefully COVID-19 is eradicated, right? You'll want to let patients know that you have new sanitizing processes, or simply reinforcing those sanitization policies that were already in place, right? And to drive a comfort level into the patient population so that they can feel comfortable returning to your facility for healthcare treatment. And with that, we want the patient volume to ramp up, right? And with that, and with that ramp up, we need to parallel that with administrative and clinical personnel ramp up that were furloughed due to the shutting down services or lines of business, right? So this will require to keep an operational pace with all duties associated to treating patients, right? And expectation is that the finance department and the department heads will keep their finger on the pulse of what lines of business are opening up, the appointments that are being scheduled for those lines of business, and that keeping a finger on that pulse will be necessary to re-engage the appropriate types of resources, human resources, to restaff those areas, right? At the same time, there needs to be probably some reassignment of staff that were in those areas hardest hit by the pandemic, right? Maybe a bit of a staff down a little bit in the ED, or staff up depending upon how your facility was hit, and you may be able to staff down in the ICU, et cetera, right? Another aspect of this with rehiring is the on-site remote equation for administrative staff. Some facilities have already enacted remote policies around medical records coding, for example. I think that's a fairly common one, right? To engage people who are remote, to codify the signs, symptoms, illnesses, and procedures of the patients that had visited the facility. However, that remote has been extended to many more administrative functions. And the question is, do you want to continue to have that remote working condition or not going forward, and for which particular types of activities that are ongoing? In terms of access management, right? And this is how to deal, this deals with the first point of contact a patient will have with your facility. Typically it's scheduling an appointment, right? To the patient physically presenting on site for the visit, right? And it deals with staffing up at the scheduling department and how to engage those patients on site, right? To the wayfaring processes, and when I mean engage the patients on site, it's for checking them in for their service. Maybe there's some wayfaring processes for the patients to make their way from the check-in, the centralized check-in, for example, to the department for where services are provided. So all humans involved, that's not only the patients, but also the staff, when they're coming back in, will have to be comfortable with engaging in these processes, right? So if I use a kiosk or a tablet for check-in information, right? The question is, what protection is in place to reduce the potential transmission of that disease, right? And then for registrars, right? In some facilities, there's already a physical barrier between the registrar and the patient. And in those facilities where there weren't, will one be installed, and will that be ongoing for forever, or will that be until, hopefully, at some point, this pandemic or the disease subsides, right? Things like how to scan an insurance card. Are we going to be handing insurance cards back and forth? Are we going to have patients actually, present that card to the reader itself for scanning, and where that reader delivers that card back to the patient, right? Will we be engaging in any types of social distancing in the ancillary departments, especially the high volumes, radiology and lab, right? There's a lot of throughput through those departments every day. How will that be managed in this time? So these are a few considerations that have to be dealt with in the short to intermediate term. Hopefully at some point we will eliminate this disease. And one example that one of our clients provided to us was the use of clinical performance monitor. Carolyn had brought this up previously in the presentation. And what this client did was they were able to data mine all those canceled visits due to shutting down the lines of business that were deemed non-essential. And they started a reach out process to those patients to reschedule those appointments. So they need to bring those patients, let those patients know they're back open for business, and let them know that they're ready to reschedule that appointment and provide them with a comfort level to return to the facility. And once those patients are in the encounter, right, that patient-clinician interaction, how is that actually going to be prosecuted, right? How's that going to take place? What does that look like? In high-touch areas, such as, when a patient presents and an E&M is necessary, well, there's going to be literally a presence there. There's got to be a co-location. And what protections are afforded the patient and the healthcare worker, right? The PPP, that has been one of the famous catch terms now with COVID-19, right? How is that going to be managed and communicated to the patient, right? And in the low-touch areas, where you don't necessarily need a clinician right there on site, but you can instruct the patient, and we've all probably gone through having an X-ray, right? You can be instructed, you can be instructed what to do without that clinician being physically in the room with you, right? Speaking from behind the closed room where they actually activate the machinery to take X-rays and MRIs, right? That can be done. We've also had a client share with us an implementation of what I guess I'll term an on-site telehealth process, where the patient is in one room and the clinician is in a separate room, and that encounter is going on through a telehealth application, although they are co-located but not in the same room. So that is an example of being able to provide, if the service needs, if there is a need to physically engage the patient, potentially during the course of the visit. That's one way of protecting the patient if that physical engagement's not necessary. And then if a physical engagement is necessary, then the precautions around a PPP. So, and then there are aspects of managing the physical plant, right? The location where patients visits, those rooms that need to be attended to between every visit, right? So the sanitization process, where there was probably a level of sanitization that was carried out prior to COVID-19. I think it put the spotlight on doubling down on efforts to ensure that a patient wouldn't contract any type of disease while visiting the facility. So that's a very important aspect of keeping that patient, number one, healthy. That's the purpose of healthcare. And also protecting them from any potential infections. Right? So with that, we are ready to move to the Q&A portion of this session.
Great. Well, thank you all so much for such a great presentation. We'll now go ahead and begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We'll try to get through as many questions as we have time for. The first question is from an audience member who's asking, what are some lessons learned from this experience, and what would you do differently when there is a next crisis?
I can take that one. This is Carolyn. So with this crisis, it was our clients had to react pretty quickly. It seemed to be a little bit rushed. I think for the next time, and it's not so much as if there's a next time, but when there's a next time, we will be better prepared. Our hospitals will be better prepared. I think maybe they will have opportunities to do some more cross-training as a lessons learned if that did not occur correctly the first time. And I think that answers it in a nutshell.
Yeah, I think, Carolyn, I'd like to tag on to that and say that, you know, when was the last pandemic, right? We could say that the avian flu or the bird flu, something, you know, probably within the last 10 years, but not as serious as this. There was a pandemic that occurred in 1969 that it just found out, and we held Woodstock during that year, right? And then I think the thing that the one that everybody points to is 1918 and what is colloquially known as the Spanish flu, right? And that's where millions have perished, right? And so I think at this point, from this point forward, we will always have and be able to engage in a meeting by which we start to engage to protect. You know, if we've relaxed how we handle patients in the healthcare facilities today, we will, I think, hopefully, fairly instinctually reenact those policies and procedures if and when the next pandemic occurs.
And Carolyn, if you don't mind, I'd like to comment also on this. One of the lessons learned is a lot of our clients basically learned that things that they had been teetering with as far as alternative work schedules and you know, working from home and stuff like that, and they never got to really explore it enough, as well as the IT side of that, right? And make people accountable and measurable and all those sort of things that come with that. They got that opportunity, right? And with that opportunity comes new opportunities in the future about how people are going to operate and where they're going to, you know, they're hiring people and keeping them accountable and working with them and making them a happy work life, that sort of a thing. But also it taught them a lot about their receivables too, because now they have the opportunity to go after those cases that may have been a little bit more tougher and challenging and stuff like that. and know that they found methods of getting them paid and bringing that revenue back in and monitoring things in a different way. And by doing that, sometimes these challenges make you better overall into the future. And those are the things that I have found out from our clients as well as my past, that those are the things that when things get really lean and mean, you have to dig in and you figure out a lot of different opportunities that you have that you don't realize when things are kind of normalized.
Perfect. Appreciate you all sharing your thoughts there. The next question is from an audience member who's asking, why was it necessary to eliminate all elective surgeries rather than just say 50%?
I think this has more to do with government mandates. Go ahead, John.
Exactly. I think it depended upon, number one, where you lived and what the local government or state government was placing as, emergency policies. I live in the state of Pennsylvania. We went on complete lockdown. We went county by county and then on complete lockdown at one point. And that was an edict of the governor who essentially stated that all non-essential services are going to be stopped. And that wasn't just healthcare, that was everything, right? And then we had a big discussion about what was essential and non-essential outside of healthcare, but that was all due to government mandate at some level.
Yeah, and John, just to comment a little bit more on that, I know there were some facilities that I was made aware of, none of all scripts, but the facilities who continued on with those non-urgent procedures and so on were actually asked to stop those. They were mandated to stop them during the pandemic.
Perfect. And the next question here is from an audience member who's asking, do you see any of your clients keeping alternative work arrangements after COVID-19?
Absolutely. I think a lot, and Terry and John, you can speak to this as well. Mm-hmm. I do see that they're finding the working from home being more successful than they anticipated. The productivity is going well, and they were able to make this arrangement work. So I think some of our clients are anticipating that it will end up being a permanent thing to work from home.
Yeah.
In addition to
my comment. Go ahead, John. Go ahead.
Go ahead, Terry. Oh, yeah. In addition to if they're renting off-site space, there's a potential for that space to go away at some point and have a cost savings. Go ahead, Terry.
Yeah. No, what we were talking about with the alternative work from home. One of the clients who I was talking to was saying, one of those things that you have to deal with is a trust factor, right? Because now you're not able to walk down the aisle or in the building somewhere and visit that person and see what they're working on and all that. So you find different ways and methods and skills to monitor, as well as you have to have some a leap of faith in managing people that they're going to do the right things and so on. And they had a very positive experience with it. And I think a lot of these clients are going to keep at least a portion of the work from home as an ongoing process. And as also, as I mentioned earlier, as something to help the workforce, please the workforce, they've earned it, let's do it. And as long as it can be effective and managed, I think you're going to see a change in how people operate.
Appreciate you all weighing in there. The next question is, what aided your clients to be able to shift so quickly to respond to the crisis?
I think what allowed them to
I'll speak up.
Was the fact that, this is Angel Ray. I think what allowed them to do this is the shared dictionaries, the configuration tools that our sites, our clients were able to quickly access so they could enable services, specifically telehealth services. Now, we have client forums. These client forums are a way for us to share with a client feature functionality, the way we can also share functionality of items that we may be working on, or maybe use them to gather feedback. And I can tell you that for a couple of months, we had client forums that were actually used where even our own clients were sharing how quickly they were able to get telehealth configured and start using it, to the point that they were sharing contact information. I mean, it's certainly the client forums, that's what they're called, client forums, right? They're intended to be a sharing, not just from Allscripts and clients to us, but it was actually the perfect setup, where then clients were able to offer their contact information so that they all could get started. It was, and so it was not something, from Allscripts stating. It was actually our clients sharing and saying how quickly they were able to do this. It was a CIO that was actually in our call that was able to share the easiness of getting that configuration in place.
Perfect. Appreciate your insights there.
Perfect. Thank you. Thank you.
Well, one other thing, though, I just wanted to expound upon, please pardon the noise in the background, is having, and Angie mentioned the shared dictionaries, and I think it's pretty important being on that single platform because it's one-stop shopping. You make a change once, and it's going to be realized by the entire database. You're not maintaining the same thing in all these different applications, which I think was pretty key. And then finally, I know that the Clinical Performance Manager, what we call CPM, which is a reporting tool not only for clinical but for revenue cycle as well, they were able to quickly get the data they needed in order to make certain decisions.
Yeah, and I'd like to jump on the back of that with, so our work queue, our work listing capability, work queues in Sunrise Financial Manager are near real time. So when you make a change to the data that qualifies for a particular work queue, we requalify the data and you have a brand new work queue if that's necessary. And we know our clients had utilized that, so what they did was they needed to not only cross-train staff, well, they had to reduce staff, and to reduce staff, they had to cross-train staff to do different job functions. And then, so when you lose a certain amount of people, right, you have a specific work queue set up for the particular areas to follow up on, whether it's pre-bill claim edits or whether it's aging or credit balances. When you lose staff, right, our clients could easily reorganize those work queues and consolidate simply by adjusting the criteria by which episodes would qualify for a work queue. And this is all point and click. It's not, somebody having to sit down and write some kind of SQL or a database query. It's point and click to determine how you want to qualify episodes for a work queue, and then the assignment of that is also built into the same functionality where you can reassign those work queues to the particular individuals who now have ownership. So it's one key aspect to literally allow healthcare organizations to turn on a dime in terms of how they operate from a business office perspective.
Wonderful. Well, it looks like we have time for about one last question. This audience member is asking, do you anticipate mobile applications assisting with patient access or the intake process to further extend protective measures? Do you foresee those extending to the future?
I think go ahead, John.
Actually, you've got this better than I do. I was just going to actually tee you up for it.
So I think this is the way that we are approaching with including or with the use of our patient engagement product, Follow My Health, as it allows us to perform, as I was mentioning earlier, the beyond just the basic appointment reminder, right? It actually provides the ability to perform several functions within that, and I know I only mentioned a few. So patient reminder is one. Certainly the validation or confirmation of the patient demographic information. But it actually does allow the patients to be able to receive information related to their, if there are any forms that they need to sign, there's any preparation that is required as the patients are, preparing for even their telehealth appointment. So there's a lot of aspect of that can take place even just from a mobile device. And that, again, this is with the use of one of our own products. And that's what it actually takes us. And it's beyond not just the caring from the financial clearance process, right, from the appointment, the visit demographics. Also, their ability to, as part of financial clearance, be able to collect an insurance card, have them scan it so that we can have access to that information. From also completing the financial clearance and payment collections. But there is also a clinical aspect of that, right? It's not just the forms. It's also, again, preparation and other aspect of data that they can provide. In addition to being able to access through their portal, which they already can access to be able to perform. They can send a question to their provider. If there is, the standard functionality they can perform as far as, sending an email and asking, for refills, they can see results of their testing and things like that. So yes, definitely, that's where we are. I think for all of us who are dependent so much on our mobile devices, and to the point that we even, if we happen to leave the house, we turn around and go back, right, and get it. It's how much attached we are to those. But it's because it gives us the access into various other areas which are outside of just patient care, our phone, being able to look at our bank account, many other access. So absolutely, that is definitely a method to get to extend, right, what relates to anything that relates to patient care, financial clearance, and some collection of specific information for us in preparation for a service that will be rendered, whether it's the telehealth service or as facilities begin to open up for other services to be able to then prepare as the patients prepare for their visit.
And I believe this will be ongoing. I mean, this was implemented during a pandemic, but I think a lot of things that have been implemented are going to continue on, and they won't end.
Right. So we've had some, we'll call it early adopters of our patient engagement platform, and then the pandemic accelerated that for some of our clients. And I think the rest of the client base will realize the power of this functionality, which I think I'll just say it just slightly different from Angie, provides the ability to push requests for information or flat out information itself. For example, directions to the facility, an appointment reminder, those kinds of things, push that to a text or an email, and a text right to a patient's device. So they don't have to access somebody else's device. They just need to look at their mobile phone or their tablet to go and perform what is needed in preparation for a visit or from follow-up from a visit. So that includes links to a link in a text message to the facilities or the physician organization's portal for filling out pre-visit information, for example, or for the appointment reminder, or for thank you for visiting. You owe a $25 copay that they may not have collected at the time at point of service. So those types of activities pushed directly to the patient, where the patient doesn't have to know where to go. The navigation is built into the text with them as a link, and it takes them to where they need to perform whatever action is requested by that healthcare organization.
Great. Well, thank you all so much for such helpful responses to our audience questions. That is all the time we have left for today. Thank you again to our presenters for such an excellent presentation, and thanks to Allscripts for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you.
Thank you.
Thank you.